Hello and welcome everyone to Sciencera. In this video, I'm going to discuss inflammation. This is a chapter from Pharmacology module. Inflammation is the body's attempt at self-protection. The aim being to remove the harmful stimuli, including damaged cells, irritants, or the pathogens, and begin the healing process. So, when you have inflammation, your body is trying to protect itself from the damaged cells. It can be from bacteria, viruses, or any kind of pathogens or irritants. Inflammation is the immune system response to infection and injury, and it has been implicated in the pathogenesis of arthritis, cancer, stroke, as well as the neurodegenerative or cardiovascular disease. So these are the things in which if there are problem with these or these types of problem in the body, you will see an inflammation reaction. Inflammation is an intrinsically beneficial event that leads to removal of offending factor and restoration of tissue structure and physiological function. The acute phase of inflammation is characterized by the rapid influx of the blood granulocytes, typically neutrophils, followed swiftly by monocytes that mature into inflammatory macrophages that subsequently proliferate and thereby affect the function of resident tissue macrophage. So what this means is that when there is an acute phase of inflammation, first you will see a rapid rise of granulocyte, then you will see a rise in neutrophils in the blood, followed by monocytes, which will in turn into the macrophages. This process causes the cardinal signal. What are the cardinal signals of acute inflammation? It is rubber, which means redness, pallor, which is heat, tumor, which is swelling, and dolor, which is pain. Once the initiating noxious stimulus is removed via phagocytosis, the inflammatory reaction can decrease and resolve. During the resolution of inflammation, granulocytes are eliminated and macrophages and lymphocytes return to the normal pre-inflammatory numbers and phenotype. The usual outcome of the acute inflammatory program is successful resolution and repair of the tissue damage, rather than persistence and dysfunction of inflammatory response, which can lead to scarring and loss of organ function. It may be anticipated, therefore, that failure of acute inflammation to resolve may predispose to autoimmunity, chronic dysplastic inflammation, and excessive tissue damage. Then we have prostaglandins. They play a role in generation of inflammatory response. Their biosynthesis is significantly increased in the inflamed tissue and they contribute to development of cardinal signals of acute inflammation. Although the pro-inflammatory properties of individual PGs or prostaglandins during the acute inflammatory response are well established, their role in resolution of inflammation is more controversial. So in this review, we're going to discuss the biosynthesis of response of a biosynthesis of and to response to the prostaglandin and the pharmacology of their blockade in orchestrating the inflammatory response with particular regard to cardiovascular disease. When something harmful or irritating affects a part of our body, there is a biological response which will try to remove it, and the signs and symptoms of inflammation, specifically acute inflammation with its cardinal signs, shows that the body is trying to heal itself. Inflammation does not mean infection. Even when an infection causes inflammation, infection is caused by bacteria, viruses, or fungus, while inflammation is your body's response. The word inflammation itself comes from a Latin word which is inflammo, meaning I set alight or I ignite. Inflammation is part of the body's immune response. Initially, it is beneficial when, for example, your knee sustains a blow and tissue need to care and protection. However, sometimes inflammation can cause further inflammation. It can become self-perpetuating. More inflammation is created in response to the existing inflammation. So the key points which we're going to remember about the inflammation is: number one, it is body's attempt at self-protection to remove harmful stimuli and begin the healing process. Inflammation is part of the body's immune response. First stage of inflammation is often called irritation. When they become inflammation, which then becomes inflammation, the immediate healing process. It is followed by suppression, which is discharging of pus. Then there is the granulation stage and the formation in the wound of tiny rounded masses of tissue during healing. Then we have acute inflammation. Starts rapidly, or you can say it has a rapid onset and quickly becomes severe. Whereas chronic inflammation, this means long-term inflammation which can last for several months or even years. Our infections, bones, or any damage to tissue would never heal without inflammation. Tissue would become more and more damaged, and the body or any organism would eventually perish or die. Chronic inflammation can eventually cause several diseases and conditions, including cancer, rheumatoid, erythrosclerosis, periodontitis, and hay fever. These are all the examples of diseases caused by the chronic inflammation. Although scientists know that inflammation plays a key role in heart disease and several other illnesses, what drives inflammation in the first place is still a mystery. It should be remembered that inflammation is part of the healing process. Sometimes reduced inflammation is necessary, but not in all the cases. Next is process of acute inflammation. Process of acute inflammation is initiated by resident immune cell already present in the involved tissue, mainly resident macrophages, dendritic cells, histiocytes, Kupffer cells, or mastocytes. These cells present on their surface contain receptor called the recognition receptor, which recognizes generic molecules that are broadly shared by pathogens but distinguishable from the host molecule, collectively referred to as pathogen-associated molecular pattern. At the onset of an infection, burn, or other injuries, these cells undergoes activation and release inflammatory mediators responsible for the clinical sign of inflammation. Vasodilation and its resulting increased blood flow will cause redness or rubber and increased heat, color. Increased permeability of the blood vessel will result in exudation or leakage of the plasma protein and fluid into the tissue, causing edema, which manifests itself as swelling, also known as tumor. Some of the release mediators, such as bradykinin, increase the sensitivity to pain, which is also known as hyperaglasia. So this is the process of acute inflammation. The mediator molecule also alerts the blood vessel to permit the migration of leukocytes, mainly neutrophils and macrophages, outside the blood vessels into the tissue. The neutrophil will migrate along a chemotatic gradient created by local cell to reach the site of injury. The loss of function or functionalisia is probably the result of neurological reflex in response to pain. In addition to the cell-derived mediator, several cellular biochemical cascade systems consist of performed plasma protein act in parallel to initiate and propagate the inflammatory response. These include the complement system activated by bacteria and the coagulation fibrinolysis system activated by the necrosis, or for example burn or trauma. Okay, so this diagram here shows the acute inflammation and chronic inflammation caused by any type of injury. So starting with the acute inflammation. Injury will be caused by infection, bacterial infection, or toxin or trauma. In case of acute inflammation, there will be vascular changes, neutrophil recruitment, and mediators. Then there will be progression, which will lead to the chronic inflammation, causing angiogenesis, molecular cell infiltrate, or fibrosis, for example, scar. Chronic inflammation results from viral infection, chronic infection, persistent injury, or autoimmune disease. Resolution for acute inflammation will cause the clearance of injurious stimuli, clearance of mediators, and acute inflammatory cell replacement of injured cells, and then normal function. This means your cell is healing now. Steps in healing will involve pus formation or abscess, and lastly fibrosis, which is loss of function. Vasodilation and increased permeability. As defined, acute inflammation is an immunovascular response to an inflammatory stimuli. This means acute inflammation can be broader divided into a vascular phase that occurs first. So, the first step in diagram shows normal permeability and blood flow. Increased blood flow and permeability of the blood vessels with vasodilation, and then increased oxygenation, nutrition, and glucose availability because of the vasodilation. So, acute inflammation, as we said, can broader divide into vascular phases that occurs first, followed by a cellular phase involving the immune cells. More specifically, which cell is involved? Myeloid granulocyte in acute setting. The vascular component of acute inflammation involves the movement of plasma fluid containing important proteins such as fibrin and immunoglobulins into the inflamed tissue. Upon contact with PAMPs, tissue macrophages and mastocytes releases vasoactive amines such as histamine and serotonin, as well as eicosanoids such as prostaglandin E2 and leukotriene B4 to remodel the local vasculatures. Macrophages and endothelial cell release nitric oxide. These mediators vasodilate and permeabilize the blood vessel, which result in the net distribution of the blood plasma from vessels into the tissue space. The increased collection of the fluid into the tissue causes it to swell, which is known as edema. This exuded tissue fluid contains various antimicrobial mediators from plasma such as complements, lysozymes, antibodies, which can immediately deal damage to microbes and opsonize the microbe in preparation of the cellular phase. If the inflammatory stimulus is lacerating wound, exuded platelet, coagulants, plasmin, and kinin can clot the wounded area and provide hemostasis in the first instance. These clotting mediators also provide a structural staging framework at the inflammatory tissue site in the form of fibrin lattice, as would constriction scaffolding at a construction site. For the purpose of aiding phagocytic debridement and wound repair later on, some of the exuded tissues fluid is also funneled by lymphatic to regional lymph nodes, flushing bacteria along to start the recognition and attack phase of adaptive immune system. Acute inflammation is characterized by marked vascular changes, including vasodilation, increased permeability, increased blood flow, which are induced by the action of various inflammatory mediators. Vasodilation occurs first at the atrial level, progressing to the capillary level and bring about a net increase in amount of blood present, causing the redness and heat of inflammation. Increased permeability of the vessels result in movement of plasma into the tissue with resultant stasis due to the increase in concentration of cells within the blood, a condition characterized by enlarged vessel packed with cells. Stasis allow leukocytes to marginate along the endothelium, a process critical to their recruitment into the tissue. Normal flowing blood prevents this, as shearing force along the periphery of the vessels moves cells in the blood into the middle of the cell. Then we have cellular components. Number one is leukocytes extravasation. Various leukocytes are critically involved in initiation and maintenance of inflammation. These cells must be able to get to the site of injury from their usual location in the blood. Therefore, mechanism exists to recruit and direct leukocyte to the appropriate place. The process of leukocyte movement from blood to the tissue through the blood vessels is known as extravasation and can be divided into number of broad steps. So step number one is leukocyte margination and endothelial adhesion. Activated tissue macrophages release cytokinins such as interleukin-1, TNF-alpha, which bind to their respective G protein coupled receptor on the endothelial wall. Signal transduction induces the immediate expression of P-selection on endothelial cell surface. This receptor binds weakly to carbohydrate ligands on leukocyte surface and causes them to roll along the endothelial surface as bonds are made and broken. Cytokines from injured cells induce the expression of E-selectin on endothelial cell, which functions similarly to the P-selection. Migration across the endothelium, known as transmigration via the process of diapedesis. Chemokine gradients stimulate the adhered leukocyte to move between endothelial cells and pass the basement membrane into the tissue. So step number one is migration, then rolling, adhesion, and then transmigration. Step number 2. Movement of leukocyte within the tissue via chemotaxis. Leukocyte reaching the tissue intestinium binds to the extracellular matrix protein via expressed integrins and CD44 to prevent their loss from the site. Chemoattractant cause the leukocyte to move along a chemotactic gradient towards the source of inflammation. Step number 3 is phagocytosis. Extravasated neutrophils in the cellular phase come into contact with microbes at the inflamed tissue. Phagocytes express the cell surface endocytic pattern recognition receptors, or you can say PRRs, that have affinity and efficacy against non-specific microbe-associated molecular patterns. Most PAMPs that bind to endocytes PRR and initiate phagocytosis are the cell wall components including complex carbohydrates such as mannose beta-glucans, lipopolysaccharides, peptidoglycans, and surface protein. Endocytic PRRs or phagocytes reflect these molecular patterns with C-type lectin receptors binding to mannose and beta-glucan and scavenger receptor binding to LPs. Okay, here in the diagram you can see there is bacterium, then adherence followed by ingestion, formation of phagosomes, fusion, phagolysosomes and destruction of microbes, and then finally release of microbial debris. So step number 1 was chemostasis and adherence of the microbe to phagocytes, then ingestion of microbe by phagocyte, formation of phagosome, fusion of phagosome with a lysosome to form phagolysosome, digestion of ingested microbe by enzymes, formation of residual body containing ingested material, and then discharge of the waste material. So you can explain phagocytosis in 7 steps if you only can remember this diagram. Upon endocytic PRR binding, actin-myosin cytoskeleton rearrangement adjacent to the plasma membrane occurs in a way that endocytosis, the plasma membrane containing PRR and PAMPs complex, and the microbe phosphatidyl inositol and VPS34, VPS15, Backlin 1 signaling pathways have been implicated to traffic the endocytophagocytes phagosomes to intercellular lysosome, where fusion of phagosome and lysosome produce a phagolysosome. The reactive oxygen species, superoxides and hypochlorite bleach within the phagolysosome, then kill microbes inside the phagocytes. Phagocytic efficacy can be enhanced by opsonization. Plasma-derived complement C3b and antibodies that exude into the inflamed tissue during the vascular phase bind to and coat the microbial antigen, as well as endocytic PRRs. Phagocytes also express opsonin receptor, Fc receptor, and complement receptor 1 or CR1, which binds to antibodies C3b, respectively. The co-stimulation of endocytic PRR and opsonin receptor increases the efficacy of phagocytic process, enhancing the lysosome elimination of the ineffective agent. Next is the difference between chronic inflammation and acute inflammation. Acute inflammation is starts rapidly or rapid onset and quickly becomes severe. Signs and symptoms are only present for few days, but in some cases may persist for few weeks. For example of diseases, condition and situations which can result in acute inflammation include acute bronchitis, infected ingrown toenail, sore throat from a cold or flu, a scratch on a skin, exercise, acute appendicitis, dermatitis, tonsillitis, ineffective meningitis or sinuses. These are all these can cause acute inflammation. Then we have chronic inflammation. This means long-term inflammation which can last for several months and even years. It can result from failure to eliminate whatever was causing an acute inflammation. An autoimmune response to a self-antigen, the immune system attacks healthy tissue, mistaking it for a harmful pathogen. A chronic irritant of low intensity that persists. Example of diseases and conditions which chronic inflammation include is asthma, peptic ulcers, tuberculosis, rheumatoid arthritis, periodontitis, Crohn's disease, chronic sinuses, and active hepatitis, and there are many more. Then we have 5 cardinal signs of acute inflammation. To remember these 5 cardinal signs, you can all remember this mnemonic called PERISH. P for pain, R for redness, I for immobility, S for swelling, and H for heat. The inflamed area is likely to be painful, especially when touched. Chemicals that stimulate nerve endings are released, making the area much more sensitive. This will cause pain. Redness, this is because the capillaries are filled up with more blood than usual. Immobility, there are many more losses of function. Then we have swelling caused by an accumulation of fluid. Heat, as with the reason for redness, more blood in the affected area make it feel hot to touch. Anti-inflammatory medications. NSAIDs are non-steroidal anti-inflammatory drugs that are taken to alleviate pain caused by inflammation. They counteract the COX cyclooxygenase enzyme which synthesizes prostaglandin which create inflammation. If prostaglandin synthesis can be blocked, pain is either eliminated or reduced. For example, NSAIDs including naproxen, ibuprofen and aspirin. People should not use NSAIDs long term without being under the supervision of doctor because there is a risk of stomach ulcer and even severe and life-threatening hemorrhage. NSAIDs may also worsen asthma symptoms and cause kidney damage. These medications, with the exception of aspirin, can also increase the risk of stroke, myocardial infarction, also known as heart attack. Then we have acetaminophen, paracetamol or Tylenol can reduce pain associated with inflammatory condition but have no anti-inflammatory effects. They may be ideal for those wishing to treat just the pain which allowing the inflammation to run its course. Lastly, we have corticosteroids. These are the classes of steroid hormone naturally produced in the cortex or outer portion of the adrenal gland. They are synthesized in labs and added to medications. Corticosteroids such as cortisols are anti-inflammatory. They prevent phospholipid release, which undermines the eosinophil action, and a number of other mechanisms involved in inflammation. Two sets of corticoids are glucocorticoids and mineralocorticoids. Glucocorticoids, which are produced as a reaction to stress and are also involved in metabolizing fat, proteins, and carbohydrates. Synthetic glucocorticoids are prescribed for inflammation of the joint, temporal arteries, dermatitis, inflammatory bowel disease, systemic lupus, hepatitis, asthma, allergic reaction, and sarcoidosis. Cream and ointments or topical formulation may be prescribed for inflammation of the skin, eye, lung, bowel, or nose. Then we have mineralocorticoids, which regulate our salt and water imbalance. Medication with mineral corticoids are used for treatment of cerebral salt wasting and to replace missing aldosterone, a hormone for patients with adrenal insufficiency.